Hello, everyone. Thank you for attending today's webinar, Kidney Status, Innovation Beyond SCR in Acute Care, presented by Bioporto Diagnostics. I'm Rebecca Kushmiter, and I'll be moderating this webinar. I'd like to start off by introducing today's speakers, Stuart L. Goldstein, Pediatric Nephrologist, Cincinnati Children's Hospital, Marlies Ostermann, Consultant in Critical Care and Nephrology, Guy's and St. Thomas NHS Foundation Trust, and Amy Pyle-Eilola, Assistant Professor of Pathology at the Ohio State Wexner Medical Center. You can read their full bios on the left side of your window by selecting the Speakers tab. Just a few notes before we begin. You can access closed captions from the bottom right corner of the video player. This webinar is being recorded and it will be available to watch on demand within 24 hours. During the presentation, please submit any questions you have using the Questions and Answers tab on the left side of your screen. Time permitting, we will conclude with a Q&A session. All right, now let's begin. Marlies, please go ahead.
Thank you very much for this kind introduction. It's a great honor to contribute to this webinar, and I would like to thank the organizers for inviting me. In the next 15 minutes, I will talk about acute kidney injury and acute kidney disease, and briefly touch on the current and upcoming KDIGO guideline. Our current definition of acute kidney injury is based on the criteria as agreed in 2012. And the definition incorporates this model of kidney disease as displayed here. Essentially, following a nephrotoxic insult, kidney damage occurs, followed by a fall in glomerular filtration and a reduction in kidney function. And if left untreated, patients develop severe kidney disease or even kidney failure. If the process lasts for more than 3 months, we call it chronic kidney disease, and any form of kidney disease lasting for less than 3 months is called acute kidney disease. Acute kidney injury is part of acute kidney disease. Now here we have the current definition of acute kidney injury and the different stages. And the definition is based on 2 biomarkers, serum creatinine and urine output. Both are available throughout the world and clinicians have a lot of experience with them. But it's also well known that serum creatinine is not renal specific. As clearly shown here, serum creatinine is the end product of the creatine metabolism, and it's dependent on many factors, in particular liver function and muscle metabolism. Serum creatinine as an end product is removed by the kidneys, mainly by glomerular filtration. But as glomerular filtration goes down, tubular secretion sets in, and this keeps the serum creatinine concentration stable. And we have to lose more than 50% of glomerular filtration before a rise in serum creatinine concentration can be detected. So the serum creatinine concentration is not only not renal specific, it's also a late marker of kidney function. And therefore, in particular, in the acute setting and in the intensive care unit, there are numerous situations where acute kidney injury may not be detected. It may be diagnosed late, or it may not be diagnosed at all. But there are also situations where acute kidney injury may be falsely diagnosed. So in the acute setting, in particular, serum creatinine is an inadequate marker of kidney function and an inadequate marker of kidney injury. Furthermore, acute kidney injury is a syndrome. It encompasses and describes hundreds of different forms of kidney disease. Even when patients have acute kidney injury from a similar etiology, they may have very different clinical phenotypes and different outcomes. And the phenotype depends on all these factors displayed here. So patient-related factors, genetic factors, chronic and acute comorbidities, but also the way we look after them and the adjunctive therapies offered and applied to patients. And it obviously depends on the form of nephrotoxic insult, the severity, duration, and frequency. So two patients with acute kidney injury, even if it's from the same cause, are never the same. And this explains why we have so many different trajectories following an episode of acute kidney injury. Some patients recover kidney function very quickly. In others, it takes longer, and some patients never recover kidney function. Some may recover, but have another episode a bit later. And all these various nuances and clinical phenotypes are not described and identified by the current definition and criteria of acute kidney injury. Certainly, the current definition does not give us any information about the underlying etiology or anatomical site of injury. It also does not give us information about the likelihood of recovery and the duration. And this is the reason why a lot of clinicians have asked for a revision of the current definition of acute kidney injury. Furthermore, as I've already alluded to, the current criteria identify patients with acute kidney injury relatively late. And it's been well described that if you look at other biomarkers, acute kidney injury may be detectable much earlier. There's certainly a period where kidney disease occurs, but serum creatinine remains unchanged. And the use and availability of new markers in combination with serum creatinine has allowed us to identify these patients with so-called subclinical AKI. And identifying them is important, as shown by this paper here, where Michael Haser and colleagues looked at the outcome of patients with so-called subclinical AKI as defined by a positive biomarker without a creatinine rise. As you can clearly see here, these patients had an increased risk of needing renal replacement therapy or dying, or both. Some of these new biomarkers not only diagnose acute kidney injury earlier, some of them also give us additional information about outcomes, likelihood of recovery, and risk of non-recovery. So in combination with creatinine and urine output, these new tools give us much more granularity to describe subphenotypes and opportunities to potential intervention. Now, I've already mentioned that acute kidney injury is part of acute kidney disease. Acute kidney disease, a form of kidney disease lasting for less than 3 months before CKD occurs. And the whole epidemiology and also terminology of these forms of kidney disease were reviewed in a meeting in 2021, where the expert team essentially confirmed that acute kidney injury was part of acute kidney disease, and that both types of kidney disease may occur in patients with different baseline kidney function. Some may have no kidney disease and others may have chronic kidney disease. And in this meeting, criteria for the diagnosis of AKD were established. And as shown here, acute kidney disease was defined by the presence of kidney disease lasting for less than 3 months, and the additional functional criteria of either acute kidney injury or a fall in GFR to less than 60 mL per minute, or a decrease in GFR by more than 35%, or a simple rise in creatinine by more than 50%, all for less than 3 months, present for less than 3 months. Now, these functional markers may or may not be accompanied by structural markers of kidney disease like proteinuria or hematuria. Now, the fact that AKD is common has been shown in various publications. A landmark paper is by Matthew James from Canada, who looked at data of more than 1 million people in Alberta, Canada. And they analyzed all patients who had at least one creatinine result available during a 1-year period. And patients were followed up for 8 years. Now, pragmatically, patients were differentiated between acute kidney injury, acute kidney disease, and no kidney disease using these criteria as listed here. And because the researchers only had potentially one serum creatinine result available, they used some pragmatic definitions as shown here. But they are very similar to the subsequent KDIGO recommendations and KDIGO criteria, which I showed you earlier. Now, importantly, they showed that acute kidney disease without evidence of acute kidney injury was actually more common than acute kidney injury itself. And what's even more important is that patients with AKD had a much higher risk of developing end-stage kidney disease or dying prematurely compared to patients with no kidney disease. And here we have the risk of end-stage kidney disease. And as you can clearly see, the risk was highest in those with either AKI or AKD on the background of pre-existing chronic kidney disease. Similarly here, these patients also had an increased risk of dying in the subsequent 8 years. So clearly AKD is common in patients. The researchers of this project showed that the majority of patients with AKD were actually detected and identified in the outpatient setting. So these were patients with significant risk factors and comorbidities, and that a lot of these patients had an increased risk of becoming dialysis dependent prematurely or dying. And so clearly more work is necessary to get more granularity and more characteristics of acute kidney disease. We should mention that the team used slightly modified criteria to define acute kidney injury because a lot of patients only had one single creatinine result available. And furthermore, in this database analysis, some important clinical context was not always present and was missing. But certainly the work should encourage us to look at AKD in more detail. So I hope I've convinced you that much more work is required to identify subphenotypes of acute kidney injury, to diagnose acute kidney injury earlier, and to describe acute kidney disease better. Work is also necessary to describe and identify patients who are at highest risk of this continuum from AKI to CKD. Fortunately, new methods and tools are available that give us more granularity and some information about these potential trajectories. I want to conclude reassuring you that the upcoming KDIGO guideline, the update, will touch on these various topics and aims to provide a definition of subclinical AKI, aims to determine and describe the role of novel biomarkers to diagnose acute kidney injury and also identify subphenotypes. And it will give guidance on the identification and management of acute kidney disease. With that, I'd like to conclude and thank you for your attention. And I now hand over to my colleague and friend, Professor Stuart Goldstein, who will continue on the theme of acute kidney injury, subphenotyping, and the role of biomarkers. Thank you very much for your attention.
Thank you, Professor Ostermann. It'll be my pleasure to speak about acute kidney injury and how we use NGAL to assist in the risk assessment for acute kidney injury. I'll present some interesting cases from the bedside at Cincinnati Children's and finish up with how we've started to use NGAL in terms of clinical decision support in a more systematic fashion. So these few cases come from a case series published by my colleague, Dr. Charles Varnell at Cincinnati Children's. And these are cases we extracted from the first 2 or 3 years after NGAL was available on our clinical platform. It's been available since 2014. The results are populated in our electronic health record within 2 hours of sending it to the lab. And currently, we have 4 different levels of interpretation for NGAL, less than 50 with low risk, 50 to 149 at equivocal risk, 150 to 300 nanograms per ml at moderate risk, and greater than 300 nanograms per ml at high risk. With the recent FDA clearance for NGAL and a new threshold based on the earnest and guidance data, we may calibrate these a little bit, but it's not going to be very much different. So let's get to the cases. Here's a case of acute kidney injury from volume depletion and poor perfusion, where urine NGAL gave direction and serum creatinine did not. The patient is a 14-year-old male, history of AML with subsequent anthracycline-associated cardiomyopathy, status post-heart transplant. He was admitted for decreased oral intake, low-grade fever, increased respiratory effort, and a low oxygen saturation. He went to the cath lab and had an episode of bradycardia that required brief chest compressions. He subsequently developed acute kidney injury with a fractional excretion of sodium of 0.05%, suggesting pre-renal or what we now call functional acute kidney injury. So let's look at his course with creatinine, BUN, and urine NGAL. On day 1, his creatinine was 0.88, his BUN was 25. Then on day 2, his creatinine bumped a little to 1.1, and we recommended a 1 to 1.2 liter fluid restriction, but we wanted to avoid negative fluid balance. On day 3, his creatinine had nearly doubled from baseline, BUN was increasing, and we obtained an NGAL, which showed now this was structural AKI, or there was a component of that, at 484 nanograms per ml. So we performed isolated ultrafiltration, understanding that he was likely not going to be able to diurese on his own. So we removed about 1.2 liters. Then you can see on day 4 and 5, his creatinine continued to climb. His BUN got up to 87. And on day 4, with an NGAL of over 1,000, we performed ultrafiltration again. And on day 5, because his electrolytes were starting to become problematic, we performed hemodialysis. Now, we all know BUN and creatinine are not going to be helpful after hemodialysis because they are removed through diffusion, whereas NGAL is not. On day 6, creatinine was 2.4 and BUN had decreased, but again, that BUN had increased from the day before, and the creatinine was low because of dialysis, but we now see his NGAL is starting to decrease. This gave us confidence that we could do ultrafiltration, but also start diuretics with furosemide and chlorothiazide. Day 7, creatinine didn't really change much because we likely were uncovering the dilutional effect as we were ultrafiltrating him more. But again, we were able to ultrafilter on that day, and we continued diuretics. And then he did just fine after that on the subsequent days with creatinine recovering on its own. And you can see his NGAL on day 9 was 143, coming back to near normal. So initially, this FENA suggested functional AKI. Urine NGAL on day 3 suggested structural AKI. He required isolated ultrafiltration for fluid removal, knowing that this was not solely functional AKI. And he received intermittent hemodialysis, which, as I mentioned, rendered serum creatinine unreliable as a marker of kidney function. Now let's go to the second case, and this is a prolonged complicated case, a patient with necrotizing fasciitis. And here, the damage biomarker really guided management for us. This is an 8-year-old boy with steroid-resistant nephrotic syndrome in relapse for several weeks, admitted for kidney biopsy, who had symptomatic nephrotic syndrome. 2 days after the biopsy, he developed necrotizing fasciitis. He was significantly fluid overloaded due to nephrotic syndrome, and the fluid he received because of his infection, and he developed a supplemental oxygen requirement. He was transferred to the ICU then for further management. On the left, we can see graphically what happened to his creatinine. On the right, we can see what happened to his NGAL and what our strategies were. On day 1, his creatinine was up to 1.48, but that had come down from 1.6, likely because of the fluid resuscitation he had received for his sepsis. He underwent exploration and debridement, and you can see his urine output was very low, and KDIGO stage 3. His creatinine bumped a little to 1.65, but on day 2, but the urine NGAL was 2,800, suggesting significant, severe structural AKI. So again, just like with the previous case, we knew he was not going to completely respond to diuretics. In fact, remember, he has nephrotic syndrome, so he also has a functional component. So we took off about 1.2 liters, we gave furosemide, and he had a pretty good response. NGAL is starting to come down on day 3, but still very elevated. Creatinine has not changed. And again, we knew we needed to get more fluid off, so we did ultrafiltration. We took 3 liters off, and he was given furosemide and had a little bit better response. And then on day 4, his creatinine is coming down, but is not back to normal. And we did another round of ultrafiltration, gave some furosemide, and he had a bit of a response, but not as brisk as before. So then he's transferred to the floor, and we continue with albumin and furosemide infusion. The kidney biopsy showed FSGS, but our treatment program here is we would start cyclosporin, but we held that because his creatinine remained elevated. Then his creatinine started to rise again on the floor, and the team was unsure if this was related to functional AKI, secondary nephrotic syndrome, or FSGS, or if the prolonged functional AKI had led to structural damage. This was clinically important to determine how aggressive to pursue diuresis with concern for adequate renal perfusion. So again, if we look at what happened, his creatinine starts to increase, and then we see on day 10 of this whole course, his urine NGAL is greater than 3,000. We give 25% albumin and Lasix, and he had a little bit of a response of about a liter. Creatinine continues to rise, and since the NGAL was so high, we did isolated ultrafiltration again, gave albumin and Lasix, and then we start to see on day 12 his NGAL coming down, even though his creatinine's increasing, but we feel that he's going to do better with albumin and Lasix, which he did, having almost 1.8 liters. And the reason we felt comfortable with that is because his NGAL had come down by almost 2/3, and we figured that this was really just predominantly functional AKI at this point. Now, let's look at this very complicated case. This is a patient who had bacteremia and fluid overload. 26-year-old male with Hunter syndrome and an indwelling port for chronic enzyme infusions, and had an abdominal hernia healed with mesh placement. The patient developed sepsis and multi-organism infection of the port and the abdominal site. His weight on admission was 130 kilos, but it was 140 kilos by the time we were consulted in the ICU. He was left intubated in the ICU after removal of the port and mesh because he had, quote unquote, an impossible airway. He was receiving vancomycin and piperacillin-tazobactam, which we know that combination can increase the risk of acute kidney injury. And in fact, he did develop stage 3 AKI with oliguria. So what happened to this patient? We have our interpretation and decision on the left-hand side, and then in the graph, in the left x-axis, we have serum creatinine, and on the right-hand y-axis, we have urine NGAL. On the first day, he had a 3.2 liter positive fluid balance. His respiratory status was worsening, and the interpretation and decision with this was fluid overload. You can see in the graph, his creatinine rose from about 1 to 3, and his urine NGAL has gone up from about 100 to 300. Then on day 2, he's 6.7 liters volume overloaded, worsening respiratory status. Fluid, again, is the interpretation, and the creatinine continues to rise. Now it's almost up to 5. But look at his NGAL in green. It's starting to come down. So we felt, okay, this is likely recovering mild structural AKI, but is more predominantly functional AKI. He was still intubated on day 3, and he was 10 liters volume overloaded. And we had the decision, should we start CRT or intermittent hemodialysis? But look at day 3 and day 4. NGAL is coming down even though the creatinine is going up. This was a big issue because he did not have a dialysis line. He had a central line that was dual lumen but would not accommodate dialysis or CRT. So what we decided to do on day 4 was isolated ultrafiltration and give diuretics, and we felt comfortable with that because again, we felt that NGAL was telling us this was functional AKI. Going back to the OR for him to get a central, a dialysis-capable line was going to be quite problematic, and the surgeons were very, very concerned he would not survive that operation. And in fact, the patient continued to do well after we did another round of isolated ultrafiltration, and he had some diuresis, and he was extubated on day 5. NGAL was absolutely critical here to help us with clinical decision support. So again, each day surgery on rounds was asking if he needed to go to the OR for HD catheter placement. Despite rising BUN and creatinine, he had good urine output as well as a normal NGAL. That gave us the confidence to recommend holding off on line placement. He continued to do well and was transferred out of the ICU several days later. Now, let's think about how we can more proactively and systematically use urine NGAL to assist in clinical decision support instead of these case series or case studies, which are interesting, but are kind of one-off situations. Right now, we are really, for the most part, still looking at functional markers of serum creatinine and urine output that don't differentiate between structural and functional change, as I've mentioned. We now have this biomarker that can assist us in determining if a patient is at risk for decreased urine output or kidney function and acute kidney injury. But what we need to do is really systematically identify who is going to benefit from the most from biomarkers. If we get an NGAL in every patient in the ICU, just like if we got a troponin in every patient who had chest pain or in an ICU, the performance is going to degrade significantly. And in fact, I've often called the land of AKI biomarkers troponin worship. But what's really critical with troponin is that it has to be obtained in the right individual who has the right risk factors and the right set of symptoms, chest pain. In fact, over 80 patients in an adult ICU will have an elevated troponin level. They are not having the acute coronary syndrome. So how do we apply, and in whom do we apply AKI biomarkers? Well, the problem is AKI doesn't have a specific symptom set to prompt evaluation. I learned on the first day of med school that there are only 3 reasons people go to a doctor. They have fever, they're bleeding, or they're in pain. But AKI doesn't really hurt unless you have a kidney stone or pyelonephritis, but patients in the ICU are not telling you, my kidney is hurting. So how do we use a biomarker? How do we direct biomarker assessment? Well, my friend Ming Chella and I came up with this concept of renal angina, modeling it after cardiac angina. And what we wanted to do is identify and stratify the at-risk population, combine this with clinical signs and/or kidney function changes to direct biomarker assessment. And as with the acute coronary syndrome or myocardial ischemia paradigm, the negative predictive value for AKI of not fulfilling renal angina should be high. We want to help the intensivists rule out patients who are not at risk and not get the biomarker in those patients, but only get the biomarker in patients who are at risk. So the way we developed this renal angina context is on the left, we had 3 hazard tranches. You could call those your Framingham risk factors. Moderate risk patients in the ICU. High risk patients are those with solid organ or bone marrow transplant or after cardiac surgery. And very high risk patients are those who have who are intubated or on a vasoactive substance. And then we combine that with clinical signs or symptoms, either changes in creatinine or volume accumulation. Patients who have very high risk need a smaller change in creatinine from baseline or smaller degree of fluid accumulation to rule in, where those who are just in the ICU need a higher change in creatinine, a greater change in creatinine or greater fluid accumulation. So now we have early recognition, patients who are at risk. We now have the functional or clinical change, so like the chest pain, and now how do we use this for a biomarker? And when we calculate the renal angina index, we look at these risk strata, 1, 3, and 5 for degree of ICU intensity. And we multiply that by either a change in creatinine or fluid accumulation at 12 hours. And that product, if it's greater than or equal to 8, tells us the patient is at increased risk of developing stage 2 or 3 acute kidney injury 2 to 3 days later. In fact, for less than 8, if the RAI is less than 8, then there is a less than 2 to 3% likelihood that that patient will develop stage 2 or 3 AKI 2 to 3 days later. In fact, the RAI with and without biomarkers has been the subject of systematic reviews, and this independent systematic review has shown that the RAI by itself has an AUC of 0.88, which is very good, and of high sensitivity and specificity for ruling in or ruling out the risk of stage 2 AKI. And when you add NGAL to it, that positive predictive value nearly doubles. So that's cool, but what about patients? So we've now operationalized this in our Taking Focus to clinical decision support pathway. At Cincinnati Children's, the renal angina index is automatically calculated at 12 hours. If it's less than 8, then the patient gets standard management. It's greater than 8, then an NGAL is reflexively ordered. No humans are involved. If the NGAL is less than 150, the patient gets standard management. They have low risk. If it's greater than 500, then our ICU is agreed to fluid restrict or consider renal replacement therapy if the patient gets to greater than 10 to 15% ICU fluid accumulated. If the patient has a middle moderate NGAL, then they get the furosemide stress test, a standardized dose of furosemide. And depending on whether or not the patient responds, if they don't have a brisk urine output response, then they go down the fluid restriction CRT consideration pathway, or if they have an excellent response, then we continue to manage them with diuretics. We've spent the last 7 years identifying if this clinical decision support pathway actually improved patient outcomes. We compared 2 eras for taking FOCUS 2. Pre-implementation for CRT patients from 2014 to 2017, and then post-implementation from 2017 through 2021. And here's the taking FOCUS 2 pathway. And looking here in the taking FOCUS 2 era, we had 71 patients who received CRT. And in the post-taking FOCUS 2, we had 107 patients who received CRT. Just want to let you know that the number of CRT patients per year was the same between these 2 eras. So, what did we find in taking FOCUS 2? Well, we found that the time to CRT initiation from ICU admission decreased by about 2 days. We also found the median fluid accumulation decreased from 12% to 4%. And we found that the percent of patients who had greater than 15% fluid accumulation at CRT initiation decreased significantly. Now, these are just process measures, but showed that taking FOCUS 2 had some impact on clinical care and clinical decision-making at Cincinnati Children's. But what was quite remarkable is that while survival to CRT discontinuation did not improve in the taking FOCUS 2 era, survival to ICU discharge did improve. Now, it's too early to say whether this is a true causation, but the association was consistent and durable over all 4 years of taking FOCUS 2. What I can say pretty confidently, however, is that CRT duration decreased by about 2 days, and that ICU length of stay and after CRT discontinuation and total ICU length of stay in patients who received CRT was significantly shorter. And my thought about this is that if you start CRT earlier at lower degrees of fluid overload in patients who need it, then they're going to be on CRT for fewer days, and likely they are going to be extubated sooner, not have the sequelae of massive fluid accumulation. So I think this gives strong evidence that integration of NGAL with a risk stratification system can aid in clinical decision support for children who are critically ill and likely to receive CRT. We also estimate that implementation of taking FOCUS 2 saved about $12,500 per CRT patient treated due to the decreased number of days on CRT and to the decreased ICU length of stay. So, in conclusion, NGAL can aid in the risk assessment for pediatric acute kidney injury in the critically ill. And I hope I've demonstrated that our pediatric clinical practice experience shows that you can start using changes in NGAL to assist in the assessment of kidney function recovery and potentially dialysis avoidance in the appropriate patient. And finally, taking FOCUS 2 shows that integration of NGAL into clinical decision support has the potential to optimize AKI management, including CRT initiation. I want to thank BioPorto for the opportunity to share our experience and our research with you. Thank you very much.
And finally, we'll be hearing from Amy Pyle-Eilola. Please go ahead.
Thank you so much. That was a great presentation. I'm going to shift subjects a little bit and talk more generically about other biomarkers of acute kidney injury. So when we think about kidney biomarkers, there's quite a few that have been around for a long time. For as long as mankind has existed, we have the ability to measure urine output, or at least get a sense of how much urine somebody's making, or if they're not putting out any urine. More recently, urinalysis has been developed, and then serum creatinine has been kind of the stalwart of kidney glomerular function for many decades. And along with that, estimated GFR is usually reported. There are some imperfections to all of these, and so cystatin C has kind of risen up in the last few decades. Not every laboratory and every institution will have this readily available, but if it is, it can be quite beneficial. And then finally, you can do a direct assessment of glomerular filtration rate, but this is kind of a complicated test and not always available in all institutions. So in addition to those shortcomings, there's some other specific challenges that most of these lack some specificity and sensitivity for kidney injury. Many factors affect creatinine, even though that's the test that we rely on most often. There's a number of physiological factors, particularly muscle mass, which can affect the accuracy of a creatinine in reflecting glomerular filtration rate. As kidney function begins to decline, some of these markers may become less accurate. And most importantly for AKI, results often lag behind physiology. So as kidney injury occurs, we often don't see a rise in serum creatinine until about 24 to 36 hours after that injury. And at that point, a lot of the damage has been irreversibly done. And then many of these really can't easily differentiate between the causes of kidney injury. So if it's like a pre-renal azotemia versus obstructive uropathy, we can't tease out the differences using just a serum creatinine. So in the last 10 to 20 years, there's been a lot of research looking for biomarkers of acute kidney injury. And these are some of the ideal traits of such a biomarker. As I already mentioned, it would reflect the pathophysiology changes in near real time. So seeing creatinine rise 24 hours after an injury isn't ideal. We want to see something an hour to 3 or 4 hours after injury when we can initiate treatment and maybe reverse some of that kidney damage. We want them to be specific to the type of injury and the location within the nephron of that injury. They ideally would be useful for disease prediction, disease diagnosis, and disease prognosis. So for each of those, you'd want a high sensitivity and specificity. Could use them to aid in guiding treatment. Ideally, they would correlate with the degree of kidney injury, differentiate between AKI and CKD. You would be able to reliably use these in the presence of other conditions such as inflammation or sepsis or low body muscle mass. And then we want something that's easily measured. We can't go and do a kidney biopsy every time we suspect there could be AKI. So we want something that we can measure in body fluid such as plasma, serum, or urine. So that brings us to this list of biomarkers. These are the ones that have kind of risen to the top through the years of bench research, animal studies, and then in human studies. These have been investigated. And the top 4 or 5 we're going to talk about in a little bit more detail. And these are the ones that are probably most widely available for clinical use. But you can see in this image that the different markers have different roles relative to the function of the nephron. So cystatin C primarily is a marker of glomerular filtration rate. IL-18, Chem1 reflect damage to the proximal tubule. The TIMP2 IGF-BP7 or Nephrology usually looks at early damage to the proximal tubule. And then INGAL usually is a marker of distal tubular damage. So I won't talk too much about INGAL because we've already heard a good deal about that from Dr. Goldstein. But it is a small protein. It's made in a lot of the tissues in our body. We believe that the primary physiological role is to affect iron trafficking. But when it comes to kidney injury, it is highly upregulated, specifically in the thick ascending limb of the loop of Henle following some kind of injury. And it can be measured in serum or in urine. So I'm going to highlight some of those ideal traits of biomarkers for each of these. So for INGAL, we can use it to reflect the physiological changes in near real time. So following injury, INGAL begins to rise measurably within about 3 hours, peaks at 6 to 12 hours, and can persist for days after injury, depending on the severity of the injury. And so this can be very helpful with early diagnosis of AKI. It is somewhat specific to the injury type or location. So again, because this does reflect tubular damage, it is good for differentiating potentially the difference between acute tubular necrosis versus a prerenal disease. And lastly, NGAL, as you already know and have heard, is very useful for prediction, diagnosis, and prognosis of AKI. And there's a lot of studies that have shown this, and you've heard about many of them. While there is some varying sensitivity and specificity shown, by and large, this is considered to be a very useful biomarker. Next, we have cystatin C. So this is a pretty small protein, just 13 kilodaltons. It's a protease inhibitor, and it's made by all the nucleated cells in the human body. It is freely filtered at the glomerulus, and for that reason, it has been developed for use in assessing glomerular filtration rate, or GFR. There are estimated GFR equations available for cystatin C, and there's a nice infographic here on the right that shows some of the advantages of using cystatin C versus creatinine to assess glomerular filtration. But when it comes to AKI, cystatin C has not been used as widely, but it still may have some benefit. We measure this in serum, and while it generally works pretty well as a marker of kidney function, there are some conditions that can affect it, including use of glucocorticoids, thyroid hormone, and just systemic inflammation. Again, with these ideal biomarker traits, cystatin C, again, is going to rise early following kidney injury. We can see that rise within about 3 hours of injury. It does tend to be not just a marker of glomerular filtration, how we primarily use it, but for AKI, it may also reflect tubular injury. And there are some studies, though not nearly as extensive as NGAL, using this for prediction, diagnosis, and prognosis of AKI. And it suggests that it may be used in AKI prediction and as well to predict prognosis. Next, we have the combination of two markers, IGF-BP7 and TIMP2. Combined, this is reported as a single result known as NephroCheck. These two markers are both made by many cell types and organs, and they play a critical role, particularly in the kidney and cell cycle arrest following some sort of injury. Like I said, when we combine these by multiplying them and then dividing by 1,000, we get a result known as NephroCheck, and that is a particular brand of test, and they have something called the AKI risk score, and that is the result that's interpreted. This is measured in urine, and like some of these other markers, is helpful in recognizing early kidney damage. This NephroCheck in particular is thought to be a marker of kind of the acute kidney stress that occurs before overt injury sets in, and may be beneficial as a very, very early marker of AKI. Again, many studies have been done on NephroCheck for disease prediction, diagnosis, and prognosis. Some large-scale studies have generated cutoffs for NephroCheck. So this is that AKI risk score. If it's below 0.3, sensitivity has shown to be 89% with a 97% NPV. So a low NephroCheck is very good at ruling out AKI. If it's greater than 2, that reflects a 95% specificity and about a 50% positive predictive value. Lastly, some studies have used NephroCheck results to aid in the guidance of treatment. So several studies have used the AKI risk score to initiate KDIGO care bundles. And following that, there's generally been an improvement in the AKI incidence, although different studies disagree about how much it actually improved final outcomes of morbidity and mortality. The last biomarker we have is KIM1, again, a small protein. This is a transmembrane glycoprotein with, again, widely expressed, though at very low levels. However, following kidney injury, KIM1 is very highly upregulated and goes from really a low or undetectable level to quite high following injury, and we do measure this in the urine. Again, we're going to see a quick change in KIM1 with detectable increase following about an hour following kidney injury. Many studies have shown a benefit in predicting AKI and the need for dialysis and prognosis of mortality. Lastly, KIM-1 has been shown to correlate with the degree of kidney damage. So that's just a quick overview of some of the more commonly available AKI markers. And I want to just conclude, because I am a lab director, with a very lab-specific note. So this is pertaining to NGAL. We have been running this in our laboratory for about 4 years, and we're able to build on some of the work done by Cincinnati Children's. And you saw from Dr. Goldstein that these cutoffs shown at the bottom of the slide are beneficial for interpreting NGAL results. The reality is that just adopting, and this is true not just for NGAL, but for most lab tests, that adopting cutoffs or reference ranges from the literature should be done with care, because not all lab results are the same from lab to lab. Shown in the table in the middle of the slide are results from my laboratory. We conduct a survey with other pediatric hospital labs that report NGAL. One of these is Cincinnati Children's, where these cutoffs were generated, where I take 5 residual patient samples in pools, aliquot those out to all of the different labs, and then I send them. So everybody measures the same 5 patient samples and reports those results to me, and they're compiled here. This was the most recent survey that we did. And you can see there's a pretty wide range of results. In sample A, we see results as low as 67 and as high as 115 between the different laboratories. So depending on how your laboratory actually is measuring NGAL, these thresholds may need to be adapted or changed. So when we implemented NGAL about 4 years ago, we worked with Cincinnati Children's, established how our assay ran compared to theirs. We saw that it was about 20% lower, and we therefore adjusted all of our cutoffs to about 20% lower than what is in the literature. That's it for me. Thank you so much, and we will open this to questions now.
All right, well, it is time for Q&A now. As a reminder, you can submit your questions using the Q&A tab to the left of your screen. We have a lot of great questions already. We'll try to get to as many as possible. And it appears that Marlies is delayed, and she will join us as soon as she's able. I believe she is traveling today. All right, let's begin. To start, first question. While it's known that one of the major limitations of creatinine as a biomarker is its dependency on patients' hydration status, does urinary NGAL face a similar limitation? Specifically, is the concentration of NGAL in urine influenced by the degree of urine dilution or concentration?
I'll be happy to take that, and I see it's from my former fellow and collaborator, Dr. Ahmad Kadura, so good to hear from you, Ahmad. Yes, so we do not typically normalize urine NGAL for urine creatinine. In many of the studies that we performed, and you were part of those, some of those, we found that while the numbers may change, the diagnostic benefit did not improve by adding urinary creatinine. And also, since we're dealing mostly with thresholds, certainly it could be that a patient has a urinary NGAL of 3,000 nanograms per ml, and if you normalize that to creatinine, could it really be 6,000? Those kind of numbers probably don't mean terribly much. They're both suggestive of severe kidney damage, so it has not been our routine clinical practice, nor have we found it in the literature to be necessary. Great question, though.
All right, thank you. Moving on. I think this is another one for you. Are there differences between pediatrics and adults in the use of serum creatinine baseline?
So the key for diagnosing AKI currently is a rise in serum creatinine over baseline, just using the creatinine criteria. There's no difference in actually needing a baseline, but what's different between children and adults is that adults see physicians more frequently, and more often than not will have a baseline measured creatinine available. In children, that is only true about 40 to 50% of the time. So what we need to do is actually impute what the baseline creatinine should be, assuming that the child doesn't have any underlying chronic kidney disease. And we've validated work by Michael Zappitelli to show the best way to impute serum creatinine. And that's been validated over many, many studies. And in fact, the FDA accepted imputation in that manner for patients for both the EARNEST and guidance study, understanding that baseline creatinine is not available about 50% of the time.
All right, thank you. For the next question, there's been a cleared indication for the use of NGAL biomarker for pediatrics in the US. Do you see other possible indications for NGAL and combined biomarkers?
So I only had time to speak about NGAL and the assessment of acute kidney injury, or to aid in the assessment of acute kidney injury through taking FOCUS 2. As you saw in some of the clinical cases, we were able to use NGAL to predict renal recovery. And I think that's one of the first ways that we were able to use it. And I think as others onboard NGAL, they may be able to use it in that way as well. We've also used it to assist in identifying nephrotoxic AKI, in fact, ruling it out, or ruling out other causes of AKI. And we've published in using urinary NGAL to differentiate between true urinary tract infection and urinary tract colonization for patients who undergo chronic intermittent catheterization, who have neurogenic bladders. I think, as Dr. Ostermann showed you, there are many, many different causes of AKI. And as Dr. Pyle-Eilola showed you, that NGAL comes just from one segment of the nephron, and there are going to be different biomarkers that will be helpful in identifying different parts of the nephron that are injured, and as well those causes that may specifically affect a specific type of component of the nephron, as well as the duration of AKI. Again, as Dr. Pyle-Eilola showed, some NGAL comes up very quickly and then may last for a few days, where others like KIM1 last much longer. So I think in the next decade, we're going to see combinations of biomarkers that are really going to give us a big picture, a better picture of the site of injury and the duration of injury, and even may give us some information about the cause of injury.
All right, I think we are coming to the end of our time, so this will be our last question for the day. If you submitted a question we haven't answered it, we'll try and get back to you individually after the webinar, including any questions for Marlies, who unfortunately has not been able to get logged in. All right, for our last question, this one's for you, Amy. The partnership between the laboratory and bedside clinicians was amazing during COVID when new tests were being deployed quickly. Do you believe that there's now a better working relationship between the communities concerning kidneys due to conversations around the eGFR changes and the new biomarkers such as cystatin C and NGAL?
Yeah, we had a really impressive rollout of this biomarker of NGAL at our institution. Our nephrology team, who kind of heard from Cincinnati Children's and saw the great benefit there, wanted to roll that out here, and they worked closely with the laboratory and closely with many other service lines within the hospital, so that when it did go live, they were ordering it very robustly in the appropriate settings. And so that's really helped kind of sustain it from a laboratory perspective as well. And it really did a wonderful job opening up the lines of communication with our nephrologists. And so we've done an increasing communication with them, including work with cystatin C and eGFR that we're about to go live with. We've offered cystatin C for a long time. But a lot of pediatric institutions haven't offered eGFR, but we will be doing that soon. And I think that's largely built off some of the initial work we did with NGAL. And if I can just build on what Stuart was saying about multiple analytes, one of the challenges that we've had in the last maybe 10 years is that while a lot of research has been done doing multivariate analysis where multiple analytes are combined potentially into giving a single result or interpretation, a lot of electronic medical records and kind of the laboratory reporting side of things have been unable to effectively kind of display that data. And I think in the years to come, we're going to see a lot more of that rolling out and adaptation of the electronic medical records to making that work a little better.
Well, thank you so much. We appreciate you for taking these questions, and we'd like to thank everyone for attending this fierce webinar and for submitting great questions. Once again, I'd like to thank our speakers for participating and BioPorto Diagnostics for presenting today's webinar. A recorded version of this will be available within 24 hours using the same audience link that was sent to you earlier. Thank you again for joining, and we look forward to seeing you at future events.